Greetings everyone, Assalamu alaikum. I am Yazan Mazen, a medical intern in Dubai Health and a graduate from the University of Sharjah. Today we're going to talk about the second glomerular disease, uh, which includes the nephritic syndrome. Previously we talked about nephrotic syndrome. Today we're going to talk about nephritic syndrome overview, what are its features, what are diseases included in this syndrome, and the details relevant for each disease, inshallah. So a brief overview, nephritic syndrome with the eye. Uh, Remember that it's including the glomerular inflammation. When we talked about nephrotic with the O, it's massive proteinuria, the O in protein. So the underlying cause of nephritic syndrome is inflammation, which leads to damage of the glomerular membrane, and this will lead to red blood cells leaking into the urine, and this will manifest as hematuria. The most common presentation, or the important presentation, shall I say, for nephritic. For nephrotic, it was linked to frothy urine or foamy urine, and also proteinuria and hypoalbuminemia. Here, look for hematuria. And when you do urinalysis, initially when you do the urine dipstick or the biochemistry part, you find that blood would be positive in the urine. Normally it's negative. But when you have positive blood in the urine, it could mean there's hemoglobin in the urine. It could mean red blood cell in the urine. It could be also myoglobin. And each one would have a name. If it was hemoglobin, it would be hemoglobin urea. If it was red blood cell, we call it hematuria. If it was myoglobin, we call it myoglobin urea. Why am I saying this? Because when you find positive blood in urine dipstick or the biochemistry part of urinalysis, you cannot say this is immediately going to be a red blood cell. It could be myoglobin, it could be hemoglobin. How do you differentiate it? We do microscopy, because urinalysis has several parts. It has the biochemistry part where we check if there's protein, glucose, blood, bilirubin, urobilinogen, and so on. Specific gravity also, but the microscopy will help us see if there's any white blood cells, to also see the shape, if there are red blood cells. It can also show us the bacteria. It can also show us if there's fatty cast like in nephrotic, or red blood cell cast in the urine, which is the case for nephritic syndrome. So the take-home message of this small bit of information is when you have positive blood, it's important that you do microscopy so that you can check if it's actually a red blood cell or myoglobin or hemoglobin. Alright, so you can find also sometimes dysmorphic red blood cells, which have different shapes, irregular shapes, because they get damaged as they enter the nephron and then exit the tubules and ducts. Another association included in nephritic syndrome is azotemia, which means high level of nitrogen containing compounds, also decreased urine production, oliguria, and hypertension. And renal biopsy is usually indicated or may be indicated to confirm the diagnosis, because they can present similar to each other, so we don't differentiate between the diseases, and also to know the stage. For some of them, we may do renal biopsy so we can confirm it and also know which diagnosis and subtype, and also sometimes the stage. And the management will be disease specific. We talked about nephrotic syndrome, how they have like a general approach, but in nephritic it's different. It's for each disease. And complication is similar to nephrotic. Both can lead to acute and chronic kidney diseases. So here's a picture about how they're different than each other. There is some similarity, but remember for nephritic that there is inflammation, which leads to hematuria, and also leads to hypertension. And Berger's disease is one of the diseases. We will talk about, inshallah, this disease and also others. For nephrotic, there is massive proteinuria into peripheral edema, hypoalbuminemia, hyperlipidemia, and also know that for nephritic syndrome, it can also manifest with periorbital edema. It's not just for nephrotic, but for nephrotic also you may expect peripheral edema. Also, when you do the lab test and urine test, you'll find hypoalbuminemia, low albumin, and high lipids. You can also find massive proteinuria like 3 plus or 4 plus, fatty casts, and so on. This is a brief overview about the normal, so that when we see the pathologies, we can see how their histology will be different, so that we can know the normal compared to the abnormal. So we can see here that these are the glomeruli, and these are different tubules. There's the proximal, distal. The white space here would be the Bowman space. Here is not very clear. but here it's much more clear. You can see this one here, and also this image here about talking when you refer to the filtration barrier, which includes the endothelial cell for the capillaries, the glomerular basement membrane here, and then the podocytes. These three make up the um, filtration barrier, which, when affected, leads to nephrotic syndrome. There are also several pictures. What you can see is the white space is the Bowman space, because I have multiple cells here, different types of cells, mesangial cells, red blood cells, podocytes, endothelia. And you can notice that the podocytes are usually at the periphery, so they're closer to the Bowman space. As another picture, limited view, you can see different cells are involved. It's very complex. So this is just if you want to know the normal, also know the different parts involved. What will be discussed today, inshallah, are these diseases. And I highlighted lupus nephritis in red because it's not uh, a specific type of nephritic syndrome per se, or even nephrotic, but it's a special type of disease. I want to discuss, inshallah, at the very end, inshallah, last slide. But these are the ones that are considered under nephritic syndrome. Streptococcal glomerulonephritis, IgA nephropathy, also known as Berger disease, Alport syndrome, rapid proliferative glomerulonephritis, good pasture, diffuse proliferative glomerulonephritis, and memory proliferative. We discussed it previously in a short manner, and nephrotic. We're going to discuss it in more details, inshallah. So first one of them is post-streptococcal glomerulonephritis. Sometimes it's also called post-infectious. It does not relate to Streptococcus pyogenes. Chili pyogenes, I'm sorry for that, chili pyogenes. But what the one thing that you should know here is that usually this occurs later or after the initial infection by Streptococcus. Either it could be an infection in the pharynx, strep throat, or bacterial tonsillitis, or in the skin, such as impetigo. And duration is usually 2 to 4 weeks. And duration is very important because this will help us differentiate it from IgA nephropathy, which we'll discuss inshallah as the next disease. And it is a type 2 hypersensitivity reaction. Why? Because the antibodies produced by the body will form immune complexes. These immune complexes will go into the kidneys, or they will form immune complexes in the kidney, They will form immune complexes in the kidney, and then this will lead to more inflammation and more immune response. Okay, so this complexes will get deposited in the kidneys. Also, some of them will form in the kidneys, I believe. So this will lead to more immune reaction, more inflammation, leading to type 2 hypersensitivity reaction. The treatment of infection is important also. That when a person gets treated for the strep throat or the impetigo or whatever or other infections, this may not reduce the risk of post-streptococcal glomerulonephritis versus the reduction of rheumatic fever risk with infection treatment. So when a person gets treatment for strep throat, this will reduce the risk of rheumatic fever in the future. But this may not be reduced when it comes to post-streptococcal glomerulonephritis. This is important to consider that the risk may not be reduced, unfortunately. So it can happen in the future. There's a chance. And patients may present with periorbital edema, or like puffy face, and also dark colored urine, or sometimes kind of board exams such as T or colored urine, or sometimes patients may describe this. There are also some different infections caused by streptococcus, which is Streptococcus pyogenes. It's type pyogen, but it's wrong. It's pyogenes. Apologies for that. And here we can see an electron microscope going to discuss its findings. So in terms of labs, you may want to check for previous group A streptococcal infection, which could be, for instance, you check for the streptolysin O, anti-streptolysin O. Also, sometimes you can check also the NSB antibodies, titers of them. You can also check the complement levels. Here they'll be low because they'll be consumed. Because as I said, they form immune complexes. So the consumption of complement will make it will lead to low levels when you do the test. Microscopy, when you do light microscopy, you find hypercellular and large glomeruli. Immunofluorescence, it will lead to granule appearance, sometimes described as starry sky or lumpy, bumpy pattern. We're going to see some pictures of it, inshallah, because many diseases also have granule appearance, so we're going to see this pattern. Electron microscopy will lead to subepithelial humps, and when we discussed nephrotic syndrome, another disease which had subepithelial deposition, immune complex deposition, was membranous nephropathy. So these two diseases have subepithelium, and we can see it here nicely here that we have the subepithelial deposit. So this will be the endothelium, basement membrane, and this would be the podocyte. So below the podocyte, which is an epithelium, so it's called subepithelial. So remember to look for these terms because sometimes disease may present with subepithelial, subendothelial, so make sure you know which one is which. And here's the granular pattern by immunofluorescence. You find that there's it's not all in a straight line. You find that it is having different lumps or different masses and different parts of the glomeruli. We're going to compare inshallah with other patterns, which when for instance there's negative pattern, but there's also linear pattern. But this is the classical picture that you see. And also I put this picture here on the right of atrophy K, just to show that the lumps at the top, there are also a lot and there are many of them. So this is described as lumpy bumpy. So lumpy means that there are many masses here and many of these lumps, and they are in large amounts. That's what we call sometimes this part of lumpy bumpy. So similar here, that you will see inshallah in this next few slides some pattern. You're able to appreciate that this is the granular immunofluorescent pattern. And when it comes to glomerulonephritis post-streptococcal type, it's described as lumpy bumpy. IgA nephropathy is also known as Berger disease. Here there is also hematuria, but the difference here compared to post-streptococcal is that it occurs during or shortly after respiratory or GI infection. Why? Because both are lined by mucosa that secrete IgA. That's why the name is IgA nephropathy. And here, as we mentioned just now, that the hematuria here and post-streptococcal occurs 2 to 4 weeks after the infection, while in IgA nephropathy it occurs shortly after the infection or during the infection. And shortly we can say around 2 to 3 days. It won't be, for instance, like weeks. It would be a couple of days. It could be like within 2 to 3 days. Microscopy, all of them would show mesangial deposition and proliferation by IgA because it's the one being involved. And by all, we mean that you have it present in the light microscopy. You're able to see mesangial proliferation and also immunofluorescence as shown here on the right. This is IgA, it was in mesangium glomerulus. Also, when you do electron microscopy, you also see deposits in the mesangium. So this is the take-home message for IgA nephropathy. Here we're going to talk just briefly about IgA nephropathy versus vasculitis, IgA vasculitis. So IgA vasculitis has different name. We may have been familiar with this name when we studied hematology and oncology or hematopoietic system. We were in year 1. The Hinosh Noeline purpura. Also, you may see this also in the pediatric rotation, inshallah, or sometimes called anaphylactoid purpura. And this is the same as IgA vasculitis. They're the same thing. And the features here can remember also by HSP, which is the name of the disease. H stands for hematuria. Patient also present hematuria here. There's a skin lesion, which is the classical palpable purpura that affects the buttock to the lower limbs, as you can see it here. These ones are usually palpable or like the purpura, and usually almost always involves the buttock and the and only lower limbs. Okay, and also there will be pain in the joints and abdomen, so HSP. And IgA vasculitis, when you remember this disease, remember that it usually affects children, especially less than 10 years of age. And it's a systemic problem, so you can see here multiple areas are involved. So the urinary system, usually hematuria, also the skin lesions, I think the vascular, so the from the vasculitis, and also there's pain in the joints and abdomen. So it's a systemic problem, and management is usually supportive. And when kidneys are involved in IgA vasculitis, we call it IgA vasculitis nephritis, sometimes called IgA-VN, as like a short form. While for IgA nephropathy, usually occurs in adults, and from its name, it usually is limited to the kidney, unlike in vasculitis, where it has multiple areas, from the vessels to the urinary system. And although IgA nephropathy is also managed by supportive treatment, it can lead to CKD and ESRD later, which requires dialysis when we reach ASRD, God forbid. And the reason I'm mentioning this is that we may find some statistics saying that around 20 to 40% of patients with IgA nephropathy may develop CKD and later ESRD, unfortunately, even with treatment. Some of them, like around 5 to 30%, will resolve spontaneously. So the take-home message from this slide, just know that they are different, although they could be similar, and sometimes you may find some articles mentioning that or some information, some sources that IgA nephropathy is associated with IgA vasculitis, but know that there are two different diseases. IgA vasculitis affects children and systemic. IgA fovealis is most limited to the kidney and affects adults. Okay, this is the take-home message. Alport syndrome, there is mutation in the type 4 collagen, and this will lead to splitting of the glomerular basement membrane, and there will be irregular thickness of the membrane, so it will be irregular thinning and thickening, as you can see in the picture here. But normally it's having a normal thickness, you can see here, but here when the patient having the mutation and the type 4 collagen, it will be having this classical basket weave appearance and like this irregular thickening and thinning. We'll discuss more about it. The pattern is usually X-linked dominant, and although we here talk about in the context of kidneys, it can also be other parts of the body, especially the eyes and the ears. Especially in the ears, you need to sense your hearing loss. So the classical triad would be can't see, can't be, can't hear, or be, and we have a similar pattern here, not similar pattern, but like similar triad mentioned in reactive arthritis or in Raynaud syndrome, which is can't see, can't pee, and can't climb a tree. So here can't hear, be, which is the ears involved in Alport. When it comes to reactive arthritis, it will be affecting the joints. So put this mnemonic as can't climb a tree. So just want to mention that because we have heard it somewhere, so just that really knows that they are similar to each other in terms of the mnemonic. In our microscopy, it will lead to the basket weave pattern, which is irregular thickening of the membrane. We have some of the pictures in the next few slides. So the basket weaver is referring to the pattern that's present in the basket, where you can see that they're coming at different angles, so or like different directions that are usually perpendicular to each other. So you can see here, for instance, that this line here is going vertical, and this one's coming perpendicular to it, and this one's also perpendicular. So you find that they're coming different directions. This is a picture above it that shows this the same thing. And here, the enter microscopy, it will show that this is the normal membrane, so it's like having a unified or uniform thickness. And this disease, Alport syndrome, we have it that there's abnormal split and laminated membrane, and also they have the classical basket weaver appearance. And look for this term as the buzzword in your exams when trying to do the boards or any exam in general. You can see that here it's not very clear, but they could be coming in different directions. But just know that it's like much wider, and there's like splitting of the membrane. So compared here, like it's uniform, having the same length. You can see if you measure it anywhere else, like from here to here, 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 different checkpoints, they're having similar length. But here it's very different. Here it's shorter. Here it's much larger. You can see. This is another disease they mentioned here about thin glomerular basement membrane lesion. But here we're talking about Alport syndrome. So focus on this picture here. This was for Alport syndrome. Now we're moving on to rapidly progressive glomerulonephritis, RPGN. From its name, that there is worsening of renal function for a period of time, and sometimes also called crescenting glomerulonephritis because crescents are formed and are generally appreciated in light microscopy. And in terms of etiologies, there are many causes, and we can differentiate it by seeing the pattern immunofluorescence and doing other tests. But immunofluorescence here is very important to help us to see the pattern and then identify what could be the underlying cause. So here you can see that we have the crescentic glomerulonephritis, and we have different patterns in immunofluorescence. We have post-immune, which is like negative immunity. There's no immune complexes present here. Linear, and we have granular. Previously I've seen granular, but today we're going to see the post-immune and linear. There's etiology and also see other pictures, inshallah. So here you can see the crescents of the protein epithelial cells, and this include different types of cells as well as also fibrin and epithelial cells, macrophages. There's a crescent here, and there's a crescent here. You can appreciate it. And we have these patterns, the linear, granular, and negative. We have certain etiologies under each. Of course, more than what's present here, but these are the most important ones, especially that these are the ones that are likely to come in the exams. They like to bring it. For linear immunofluorescence, just remember one disease, Goodpasture syndrome, sometimes called anti-glomerular basement membrane disease. So when you have linear immunofluorescence and in the context of rapidly progressive glomerulonephritis, think of this disease. And we're going to talk about it inshallah later. Next slide, I believe, or the next disease. For granular immunofluorescence, think of immune complex mediated diseases. One of them is post-septococcus glomerulonephritis. So So this is one disease you should look for. It can lead to rapidly progressive glomerulonephritis. And another cause would be SLE, because when kidneys are involved in a patient with SLE, we call lupus nephritis. So sometimes they can also have progressive glomerulonephritis. So think of also SLE. And also other diseases, by the way, that are present, such as for instance, that can cause a granular immunofluorescence pattern leading to or associated with rapid progressive glomerulonephritis, such as proliferative glomerulonephritis, and I think IgA nephropathy. There are many diseases, but just know these two for the sake of boards and exams. We have negative immunofluorescence, or called post-immune. We think of two classifications. We look for C ANCA, or sometimes called PR3 ANCA, and P ANCA, or MPO ANCA. This is very important that you should know them. These are very important because this also recur inshallah when you go over vasculitis. C ANCA and P ANCA are important. I like to mention them also to other diseases. When we think of C ANCA, we have one disease which is gramatosis cholangitis. This is also known as Wagner gramatosis. So think of this disease. When we have P ANCA or MPO ANCA, we have two diseases. We have eosinophilic gramatosis with cholangitis, something called Churg-Strauss syndrome or Churg-Strauss disease, and we have microscopic cholangitis. So the take-home message from this slide is just know that disease involved in each one. So if you have, for instance, they're talking about, the exam question is talking about rapid progressive glomerulonephritis, and then they're mentioning that there's a granular immunofluorescence pattern, I will show a picture, they tell you, think of these two diseases as the most common ones, or like the important ones. If they mention it's negative, think of these two, and if they mention C ANCA, think of this disease. If they mention P ANCA or like other form of it, know these two, P ANCA or MPO, C ANCA or PR3, think of these diseases, alright? This was for rapid progressive glomerulonephritis. We'll talk about good posture because I've seen previously, just in the last slide. It's also known as anti-glomerular basement membrane disease. It's one of the causes of RPGN, and this is due to antibodies against type 4 collagen in the membrane, in the glomeruli, and also in the alveolar basement membrane. And it's a type 2 hypersensitivity because the antibodies attack this antigen. They go and attack these antigens. And it's unlike Alport syndrome was the mutation. Here's there's no mutation. It's actually autoantibodies attacking these antigens. And they present with renal involvement and respiratory involvement. Renal can present as hematuria. Respiratory, think of hemoptysis or cough or even dyspnea. Sometimes it's also referred to as pulmonary renal syndrome. And when we also go inshallah over the vasculitis, we will see that vasculitis, they like to involve kidneys and also other parts. Sometimes they involve the lungs, sometimes they involve the sinuses, or the also sometimes they associate also with asthma. So each one have a pattern. When it comes to good posture, it's only the lungs and the kidneys. Think of them, these two areas, because this is where the lesions are involved, like in the collagen and the glomerular basement membrane and the alveolar basement membrane. And irreversible pattern, which show linear irreversible pattern. There's a clear picture here that I want also to show you. So you can see both of them have similarity, that both seem to be connected like into straight lines. That's why this one initially for me, I also thought this one would be linear pattern, but when you see that they're like different dots and like having this granular pattern, like when we see for instance neutrophil, or I've seen also previous slides like for post-surgical glomerulonephritis or even for RPGN slide, you know that there are like some dots and like some lumps, you can call them, or masses. This is what will make it granular or make it also having this granular immunofluorescent pattern. But here linear, it is smooth and continuous, and there's no gaps, as also mentioned here. Also, there's no like these little masses or dots or lumps, yani. And this, unlike here, for instance, you have these different depositions of immune complexes. So hopefully this picture will have to clarify between both. Remember proliferative glomerulonephritis? We've talked about previously in nephrotic as a brief overview, but here as a way to revise, we should know that it can be mixed with nephrotic syndrome, so they have nephrotic pattern. Okay, so although it's under nephritic syndrome, can also sometimes be under nephrotic. Sometimes both can be present under membrane proliferative glomerulonephritis. The deposition of antibodies and complement fighting the mesangium and on capillary walls, which will lead to, or is associated with splitting of the glomerular basement membrane. Look for this term, double contour or term like appearance on microscopy. This will be like a key word or phrase. And the different types there's type 1, type 2. I remember reading from also there's type 3, but for example, just talk about these two. Type 1, look for association with hepatitis B or hepatitis C infection, so that it could also be idiopathic, and the pattern would be subendothelial immune complex. It's subendothelial. Type 2 is associated with CT nephritic factor, which is an autoantibody, IgG, that stabilizes and activates C3 convertase, and this leads to continuing activation of the complement system, leading to low C3 levels. And here it's intermembranous. When we talked about membranous glomerulonephritis, it was subepithelial, right? And also when we talked also about post-septicoccal glomerulonephritis, it was also subepithelial. But here it's subendothelial or intermembranous. Okay, so remember to look for these terms, even for this one, double contour, TAMTAC. Okay, and here you can also see the time to show the TAMTAC appearance. I hope it's clear. Also here the time to show about how this layer here and having all this complex deposits such as present and proliferative glomerulonephritis can be present. So you can see that there's this gap here and there's the splitting of the glomerular basement membrane. Okay, so look for that and under microscopy. Talk of diffuse proliferative glomerulonephritis. From its name, diffuse means involves more than 50% of the glomeruli. Remember we talked about it in nephrotic when we compared focal segmental glomerulosclerosis to the terms focal and diffuse. Diffuse means more than 50%. Proliferative means as increased cellularity in the glomeruli, so it's increased cellularity in more than 50% of glomeruli. Look for etiology, especially SLE as the common underlying cause, also IgA nephropathy. And this is similar to member proliferative, that both it can present as nephritic and nephrotic syndrome together. This is a point that you should consider. Not many diseases have this overlap, so far I've talked about two diseases, member proliferative glomerulonephritis and also diffuse proliferative glomerulonephritis. Microscopy, look for wire looping of capillaries or either from the histology or microscopy they put for you in the exam, or they mention it as a buzzword in your exam. Also granular pattern, like we talked about in diabetic progressive glomerulonephritis, that it has this granular pattern similar to post-septicoccal glomerulonephritis. And under microscopy, it's also subendothelial. Sometimes it can have subepithelial or intermembranous, but look for subendothelial as a key phrase. Here you can see that there's thickened capillary loops because this is inside the glomeruli. You can see it's thicker. Usually it's much thinner. This is a magnified view. There's also another picture. You can see it's much thickened compared to the content here. This is thickened. I think not as thickened as this one because of your lesion. Homogeneous thickening of peripheral capillaries. Subendothelial deposits. So keyword is subendothelial, but as we saw in the previous slide, it could have subepithelial and intra-membranous. Last thing we talked about is lupus nephritis. Lupus nephritis means when nephritis happens second to SLE. Okay, so this is what it means. And kidneys are unfortunately commonly affected in SLE patients, and it's a major cause of morbidity and mortality. The reason why I want to mention it here as a special disease is because it's not present per se as an individual disease in nephrotic or nephritic syndrome, because it can actually have both. It can present as nephrotic or nephritic syndrome. Now, if we look on the right side of this slide here, we have the classification of lupus nephritis. It has different stages. That's why it's important to do the biopsy to help us to know the stage. The first one highlighted is class 4, which is diffuse proliferative nephritis, which is the same as what we just talked about, diffuse proliferative glomerulonephritis. So if the patient has this pattern, so the patient has SLE and has the kidneys involved, we did the biopsy, we found that that's class 4. That means the patient has nephritic syndrome. This is nephritic, because it's the same as diffuse proliferative glomerulonephritis. If it was class 5, as highlighted here, membranous nephritis, this is the same as membranous glomerulonephritis we talked about in nephrotic. So here it should be nephrotic syndrome. Even the patient has lupus and patient previous stage had nephritic, here it can be nephrotic. So just want to mention here that lupus nephritis is not by itself under nephrotic or nephritic. It depends on the stage and can present with both. That's why it's important that you consider it, and there are many stages involved, and it's a complex disease, and fortunately kidneys are involved in SLE patients. So when you treat a patient who has SLE, remember to check kidney function and monitor it, as it is commonly involved and it's the leading cause of morbidity and mortality in such patients. this concludes this video. I hope it was useful to all of you, inshallah. And if you want to refer to there's a separate video for it that you can, inshallah, watch it and inshallah get benefit from it. Thank you very much for listening.